asked to do the extension side bending rotation test, you should pretty much know kind of what you need to do, right? It's not overcomplicating it, right? So come stand here, face them, cross your arms, right? So we're gonna put one hand on the sacrum. The other hand is gonna wrap around the shoulder, and guess what we're gonna do? We're going to extend them, side bend and rotate. Okay?
Rotate ipsilateral.
And we're looking towards, for reproduction of symptoms on that side, right? Because think about what we're doing, and this is what you gotta visualize, right? So grab a spine, right? If we extend, side bend, and rotate, right? Those three combined motions are gonna compress the facet joint, right? Because right rotation gaps that side, but when we extend and side bend, it creates compression. So a reproduction of symptoms on the same side is indicative of a facet joint issue, right? Which is gonna be low back pain with
Mobility
deficit, right? Now, to your point, you said ipsilateral side, right? You can go to the contralateral side, right? So I can stand here, I can extend, side bend, and rotate. The problem with this is, right, if he goes, he's taking me with him.
Yeah.
Right? So it is a little more awkward to have to get into a squat to come into the same direction. But I personally, personal bias, recommend staying on the same side because then you're in a good position. So if they, have an issue, you can give them the hug and move on. Right? Now, if the person is vertically, right, at a difference for you, or from a size different from you, you can do it seated on the table. Right? So the same thing, cross your arms. Right? From here, I can extend that, rotate.
That didn't feel good.
All right, so indicative of a facet joint issue.
And this is completely passive for the patient.
Completely passive. Right? We're just trying to take that facet, smash it.
So are you adding any pressure at all, or
So,
maybe after?
so as you combine,
Yeah.
those facets are going to compress, and that's the only place you can go.
Yeah.
Right? It's going to end up being a hard end feel.
Right.
Pressure's bone.
And that hits
Yes.
L1 through 5?
Yes.
Okay.
So if it happened, in this case, if he had stenosis, this would aggravate it?
Yes.
That did hurt.
Yeah. Okay, next up, centralization assessment during movement testing. So, this is assessing for that referred pain, right? So if you have low back pain, it's going someplace else, neurovascular screen negative, next step is looking for that centralization, right? So that's where we add in repeated movements, right? So you have the patient put their hands on their hips, right? And you say, all right, I want you to just arch back, right? And start with 10 times, right? And you just ask them, does that change anything? Does it make it better? Yes, it makes it better. Okay, what's happening, right? Less pain, or well, it was in my heel and now it's in my butt.
Positive.
Okay, positive test indicating referred pain, right? And at that point, that would start the treatment process.
You could turn that into a treatment.
Yep. And that's honestly, right? Because what did I just do? I just showed the patient that if I move a certain way, it gets better, right? And then I say, there's exercise number 1. Every hour, I want 30 of those. Right? Pay me, I'm out. Right? And it really is that simple. Right? A patient like that, that's what the patient gets to go home.
Are you doing no core? Or are you
No, no core, it's just, right? And that is the McKenzie method. Part of it.
Another ring pop.
Right? Right? It works. It's great. It's simple, right? And patients don't need 10 exercises to have an exercise for an hour. Right?
And for a patient like that, you tell them to avoid flexion, just only extend.
Within tolerance, right? Because we eventually want to get them to flex. So we tell them if it's a position that's aggravated, then stay out of it, right? But we want to work back towards that. And typically that's going to be in clinic, right? So I'll check with them. It's okay, extension is better, that makes it better. Then I'll get them on the table and hook line. How does that feel? Yeah, no, symptoms starting to come back. All right, get you up, right? Or get you prone, right? And do press up stuff, right? It's all listening to your patient. And that's why every time the patient comes in, you get asked those questions, right? And get the update. Next up, lumbar side glide, the lateral shift correction.
What number are we on?
Three.
Oh, number 3 was on. Intrusive thoughts. Do you know where that's from?
Just kick this.
From Shrek.
All right, so
Oh, boy.
a lateral shift, right, is typically going to be a test that is a result of low back pain or radiating pain as a result of a disc herniation. Okay. We're gonna go through the test today. I'm gonna explain it on Thursday, because that's gonna be a whole nother ballgame. All right? We'll get the pictures back out, do some nice drawings. So a lateral shift is when the trunk moves over the pelvis. Okay? It's not a side bend. Right? It's a side shift. Right? It is named by the top down, so whatever direction the shoulders go, so this would be a right lateral shift. Okay? This is indicative of a disc herniation. Okay? Now, with that,
Is this kind of like what Mommy had?
Yes.
yes.
Alright.
You don't know?
No, it's like, no, I.
You ain't.
You don't know? Now you know.
Send him another.
You don't know, don't be asking.
No.
All right. So, lateral shift, right, is actually, you're right, can be one of those things that's a little bit scary, but it's one of the easiest things. Like, I love when it walks in the door, because when I see that, I don't even need an email. I already know what I'm doing, right? Yes, you gotta get the patient back up and centered, right? So if there's a disc herniation, the body's gonna lean, right, or shift into a direction to make it less painful, right? And because of that, if you look at this, do you think I can manipulate anything?
They're in a bad position.
Right, you're in a bad position. So the only thing you can do is get them upright, right? And so, when it comes to a test, what we're gonna look for is to see if this is going to be an example of a treatment that's gonna be useful. If it's not, then when we get into treatment, I'm gonna show you the McKenzie method of how to work through this, right? But this is one of those, we tell you that things are really, really simple. When you see somebody walking like this, it's almost like when somebody walks in with thoracic pain, right? Right? Because as long as it's not a cardiac issue, as long as it's not a pulmonary issue, I'm nipping that, right? Because it's either a rib or it's a facet joint, and life is gonna be good. That patient's gonna get better. I want those patients, right? Same thing with this, right? So, patient is shifting, right?
It turned into a dance.
Alright,
All the
so,
boys are in the yard now.
we got the shift, right? So all I'm gonna do as a part of the test, right, is I'm gonna do little oscillations.
Good angle.
So I'm gonna wrap my arms, right, around to grab onto the hip. And then I'm gonna put my shoulder into his axilla.
Oh, you're literally.
I'm literally
shifting him
gonna
back.
shift him back. So all I'm gonna do is I'm gonna pull with my hands and push with my shoulder into little oscillations, trying to work him back to neutral.
So you're working the whole spine together.
I'm working the whole spine together, right? I'm not side bending him, so I'm not doing this, because that's gonna be painful, okay? But what I'm gonna do is just oscillate gently, right? And say, how does that feel? Okay, that feels okay, right? That doesn't feel okay? Done, stopping, I need to do something else.
When we're doing this, we don't necessarily have to focus on moving the shoulder.
It's
just kind of
Bringing them to you.
from the hip.
We're pulling from the hip, pushing through the shoulder.
And the patient's already going to be presenting in that posture.
Yes, they're already gonna be there, and I'm just wiggle, 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 wiggle. And if they say, okay, I get to a point where we wiggled and we're here, then I know what my homework's gonna be. If I can't move them at all and it's not good, then I'm doing something different, right? So it's an assessment to see, is this treatment gonna work for a patient with a disc herniation, right? One of the other considerations with this is notice my positioning, right? And whether male or female, right? I wanna be here, right? Because otherwise, then I'm here. Right? And, right, that's not an area I wanna be in, right? Personal bubble, chest area, right? So this is one of those times where we always wanna see the patient's face, so that's why you use a mirror in the clinic, and put yourself in a position where you can see the patient through the mirror, but you just want your head behind, because it's just more comfortable for everybody involved, right? Awkward, right? So, yes?
Speaking anatomically, shouldn't doing this, like pulling up here, pushing down here, shouldn't that just make the symptoms worse?
Okay, so,
Because they're putting themselves in this position to feel better?
yes. And that's what we're gonna talk about Thursday. So today, we're not gonna worry about the whys, because we gotta actually map things out and talk about the physiology of why this happens. all I want you to know for today is that if they're shifted, we're gonna try to wiggle them back, right? If you can't wiggle them at all, then we're gonna do something different, right? If you can wiggle them, right, then that's your treatment. If you can wiggle them all the way, that's your treatment, and then you can start treating once you have them back up, right? And to the point, we'll throw in a little treatment here just because it makes sense, right? So if they're shifted here and I do the wiggle wiggle, and even if I get them halfway, right, then their home exercise is to stand against the wall and wiggle, 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 right? A minute every hour until you get straight, right? And most of the time, if they're able to wiggle, wiggle and get a little bit better, then what I tell them is wiggle, wiggle till you're upright, then call me, and that's when the second visit is. Because that's when I can do something different. If they can't wiggle at all, then I'm seeing them 2 times a week because I gotta get them on the table and I gotta do stuff with them for at least a session or 2. But it's a nice test to say, is this gonna be an appropriate treatment at this time? Because, to the point, we're pushing it back into the pain, but that's no difference in the concept of directional preference, right? If they're better in extension, eventually I gotta get them in deflection, and how am I gonna know if I get in deflection? I gotta push the limits every now and then.
So once you wiggle them, like from here to here, are they staying there, or do they like shift back?
Could go either way,
Okay.
right? And that's where, if we work through the healing process, ideally, once we get them upright, they're upright. And usually, once they get them upright and you can fix the underlying problem, it doesn't shift back. But a lot of times it does. A lot of times we get them straight, and the next time they come in, boop. And we just keep following the cycle until we get them straight.
If you can't do it standing, how, like, because you can't do it sideways. Oh, I'm sorry.
Can we wait till?
Yeah, sorry, I got excited. All right.
Right, good, we like getting excited. So yes, we can put them on the table in supine or prone, get them into a position of comfort, and I'll walk you through the steps. Right? But same principles, right? Where can they tolerate? Where can they not tolerate? And let's always push the limits.
This usually is a muscular issue.
No. This is
HMP.
usually disc. Right? It's not to say that you couldn't get nasty muscle guarding, but for the guarding to create, if there's muscle guarding, right? Even if you look at the iliocostalis, right? Going from the lumbar spine up into the thoracic spine, right? That's going to create a side bend, not a side shift. Right? Which is why I stereotypically say if this walks in, right? We can fix that. We can work on that. Right? Okay. Next up, palpation for lower lumbar step. Cross that out. Put a big red X through it. Right? Anywhere you see it ever, right? So the thought process is this is what we're going to talk about with movement coordination, right? And when you have a slippage of a vertebrae on one or the other, that's where spondylosis is going to turn into spondylolysis or spondylolisthesis, right? It talks about palpating, right? Something that we can't palpate, right? We can't palpate this. Originally we thought we could. Right, it's been disproven in a number of research articles. Really, the only way that we can look at that and see what's there, which we're going to talk about next Monday, is via X-ray. So some people will say you can do it, you can't. Right, and if you can, then there's going to be a serious problem, right? Because you probably already have caudal equina stuff going on, right? So just take that one out.
So I'm not going to see that on this exam.
You're not going to see that on the exam. Right, so those are talking about the first 4. So obviously 2 is pretty simple, but you should at least talk through it, right, with the repeated movements. But go ahead and do the extension rotation side bending test, do the lumbar side glide, and then we'll come back and talk about our instability stuff.